Well, welcome back to the Equip for Life podcast. I have two very special guests with me today. Let me introduce them real quick, and we are going to dive in to a great discussion. We've got John Bockmann here, who's a military physician assistant and co-author of Reconsidering Fetal Pain with Dr. Stuart Derbyshire. Some of you have already heard a little bit of that story from either me or perhaps as Secular Pro-Life, so we will be talking about that. We are also joined by Dr. Bridget Thill, is a former Air Force general practice physician who cared for military personnel in the U.S. and overseas before transitioning to medical bioethics. She received her master's degree in bioethics from the University of Mary. She works as an independent researcher and writer in medical bioethics. So we will be talking about fetal pain today, and particularly what these two researchers who just know way more about this than I do have been learning in the last several years about this topic. But before we get into kind of the real scientific details, I want us to take a few minutes and talk about how did this paper that John wrote with Dr. Stuart Derbyshire happen? So for those of you that don't know, basically, John, pro-life guy, reached out, here's my understanding, reached out to a pro-choice researcher who's been very public and published multiple times on fetal pain, going and had, I think, roughly the standard line of fetal pain probably couldn't begin before like 24 weeks. And then you have some kind of a correspondence with him, and it ends with you guys co-authoring a paper saying that fetal pain might begin as early as, I think, 13 weeks. You will correct whatever I get wrong, but that is a huge deal. So just like at a persuasion level and a dialogue level, like how did that happen? Tell us the story.
Well, thanks for that glowing introduction, Josh. And I'm as amazed by that story as anyone, having taken part in it. It didn't happen all at once. I'll say that right now. It happened over the course of several years, many conversations, some in person, probably most via email. As you may know, he is in charge of the imaging center at National University of Singapore. So time differences, great geographical distances. And so it's a very unlikely meeting, but as you pointed out, it all began with me reaching out to him and him just coming back. So I was shocked and surprised because I'd read about him throughout my research for my fetal pain thesis in PA school in in 2015, I just started PA school, kind of midlife change, and his name came up on pretty much everything to do with pain at all, and certainly on fetal pain. And he was part of the working party who wrote what many consider to be the last word, the authoritative word on the topic of fetal pain, Royal College of Obstetricians and Gynecologists 2010 report of fetal awareness. So that report said no fetal pain before 24 weeks, as you mentioned. And then the kicker was, or possibly at any point during pregnancy, during gestation. So that was
really?
Yes. So a lot of people don't realize that. So that paper really was like, yeah, these neurologic structures are necessary, but they may not be sufficient because the fetus may be in a soporific state, sort of like sleepy, anesthetized. They said, that was the hypothesis because they did some research on a bunch of fetal lambs. So they're like, okay, and if we extrapolate to the human fetus, then well, we can infer that the human fetus is never awake during gestation at any point up to birth. It just wakes up just as it's being born. So
wow,
so that's pretty wild. So that was his position. Just to clarify, the daylight came when I read a 2013 article in the New York Times in which he seemed to be walking back that position. He's like, it's a really interesting position. I'm afraid it just doesn't work though. And I was like, that bothered me. And I saw it and I put it aside. There's volume, like huge amount, Bridget knows, huge amounts of research that bears on fetal pain, from philosophy to neurology, to, anesthesiology to pediatrics, you name it, just every single thing you can think of. And so I put that aside. And then I was about to have to turn in my fetal pain thesis in 2016, May 2016. It's been almost 6 years now. And I was like, you know what? I really got to know what this guy thinks because he's everywhere. And if he thinks there might be a little smidge of daylight, I'm really curious. This belongs in my thesis. So I emailed him. And the next morning, I emailed him during class. And the next morning it came back and it was like full page, like response. And I couldn't believe it. And so that began basically several years of talking. We wound up meeting, and it's a story in itself. I'll spare you the details for now. But yeah, very, very interesting. Couldn't hope to duplicate it if I tried.
Go one level deeper. I know you don't want to tell all the details, but I'm so curious. Just like a little bit, just tell us a little bit about maybe at a 10,000 foot view, what those few years were like. What was the evolution? What were the, like, what was like were the catalyst to his mind being changed? So like, I mean, in a massive way,
right?
Like just a little bit about that.
Yeah. So, in ARCOG 2010, that's what I'll call it for shorthand. Bridget's on the same page. So in ARCOG 2010, it just mentions the idea that there could be a sort of a rawer, R-A-W-E-R, a more raw pain experience than something that's really cerebral and fully understood and, you know, cognitive, and requiring, in the view of the authors of that report, a cerebral cortex, sort of the last portion of the brain to develop both in, evolutionarily and developmentally. And so the idea of being like they couldn't feel pain until maybe even a year, it's postnatally in some cases, some people thought. But there was this little thing inside ARCOG 2010 that's, it acknowledged that there could be some rawer version of pain that didn't require all this knowing that I'm in pain. It could just be being in pain. And so that struck me, and both Bridget and I picked up on this as possibly authored by Stewart. It turns out we were correct. And it's Derbyshire, by the way. That got me for years. I didn't know until I met him, and then I was like, "Really? That's wrong. They pronounce your name wrong."
I've been getting it wrong for years in public.
Derbyshire.
So I'm glad to know.
Yeah. So anyway, let the record show. Yeah. So all that to say is a lot of Stewart's change in mind had to do with the idea that maybe we don't need to force this more mature definition of pain onto a fetus, because if we do that, then it also applies to animals. It applies to very young postnatal humans. And what's the justification for that? And frankly, as Bridget and I both agree, there really isn't any. And or let's give them about 5% credit. There's very little reason to do that. So that was the first thing. And is the definition of pain. It doesn't have to be too complex. It can be pretty basic, such that an infant, an animal, or even a fairly mature fetus, or even a younger fetus could feel pain. So secondly, there's the idea that the cortex I mentioned earlier, their outer part of the brain, needs to be developed and connected to the spinal cord and the periphery, the fingertips or wherever might feel pain, in order to feel pain, because the cortex is the higher level thinking, the cognition. You may have heard of the frontal lobes. That's the prefrontal cortex right up here. That synthesizes a lot of our response to stimuli and decision making. It's the executive brain, essentially. So what we found in a couple very key papers was that that cortex seems not to be required. In fact, there were some purportedly specific areas that dealt with pain. They were called the pain matrix. And everybody was certain through functional MRI, magnetic resonance imaging, fMRI, that these areas lit up during when the patient was feeling pain, and they didn't light up when they weren't feeling pain. And so that just proved that these areas, this pain matrix in the cortex, was the key capstone to the pain experience, without which you would not have pain. Well, a couple studies with Feinstein. They're 2016. Feinstein and Solomons is involved in both. Tim Solomon's involved in both papers. And one of them had to do with Roger. He didn't really have these pain centers. He had some brain damage earlier on. He was about a middle-aged guy who lost some of his brain, including most of these pain centers, almost all of these pain centers, pain matrix. And yet he had not less pain. He had more pain. He had hyperpathic pain. And so we thought, and there's a lot more to it than that, actually, but I'll spare you the details. But that point seems to be the less of these pain centers you have, the more pain you feel. So that was a striking study. Secondly, there was another study with Tim Solomons, as this time the lead author, the pain matrix in pain-free individuals. So these individuals that he studied had congenital insensitivity to pain, CIP, and they put them through noxious stimuli testing. The pain centers, purported pain centers, lit up, but the patients with CIP felt nothing. So we're like, okay, well, these pain centers of the cortex, what are they telling us? We don't need them apparently to feel more pain, and if we have them, it doesn't guarantee we feel pain at all. And they look at on the fMRI imagery, they're lighting up, but they still feel no pain. So as we said in the paper, this seems to neatly dissociate pain from the cortex. I mean, we realize there are others possible studies that may suggest to the contrary, but this seemed to be a pretty clean break, pretty strong break, I would say.
Okay, so before I turn things over to Bridget and we'll get more into the science of this, just one more question for you, John, about this paper. Like, a lot of the people who listen to us are learning, generally speaking, about dialogue, about persuasion, about philosophy. How do we have better conversations with people who believe different things than us? And I'm just wondering, you had a really interesting experience. What advice would you give people, generally speaking, on how to be persuasive? What is it that you think that you did well in your interactions with, now I don't even want to say his last name because I'm going to screw it up.
Derbyshire. Yes, Derbyshire. You just have to like forget what you read. And it's like when you see the color orange, but the word says red, you're supposed to say red, even though you're looking at orange. That's like Derbyshire. Okay, so yeah, good question, Josh. And Bridget and I have talked about this, and I've told this to anybody who will listen. I think that this is at least as big a story in most ways, in many ways at least, as the actual paper itself, is the collaboration behind the paper. Because Stuart Derbyshire is an inveterate pro-choice activist, scientist, skeptic of fetal pain. And so I really can't take credit. Okay, so let me just say this. Without Stuart's openness, none of this would happen. I would have had zero chance. And in fact, this is true for most people that I've come in contact with, at least on the superficial level. Like, yeah, I'm always looking for an opening, but unless they're open, it's not going to happen. So I would say just don't force anything. Just be curious. So I was curious. The other part of it is I did ask a lot of questions, and he was gracious enough to engage me in conversation. I did have some background in philosophy and arguing online and evolutionary stuff. And I obviously had done my homework, so I knew the stuff that he had written. I knew the stuff that was out there. So that gave me, I think, a measure of credibility. Plus, he's a friendly guy, you know, and he's surprised. I would have misread. I would have never guessed that necessarily from some of his more vociferous denunciations of fetal pain. And then finally, I couldn't bear it anymore. And I said, Stuart, this ARCOG 2010 paper is wrong. And I think we would both agree that this part of the paper is absolutely wrong. And I think the world needs to know that it's wrong, because we're getting hammered in the pro-life area for saying that fetal pain exists, when this paper quite erroneously and not scientifically says that fetal pain is not possible for 24 weeks. And so that's when Stuart was like, hey, you want to publish a paper together? I was like, yeah, but on what?
That's
on what? So honestly, staying open, just being friendly, using whatever I had at my disposal, I think is the answer to how this happened. Plus his openness.
That's just an amazing story. Okay, so Bridget, let me jump back to you. You've been super patient. I've got a few questions for you, and hopefully we can all just kind of interact about this. But I'll say, Bridget has put together some really, really cool slides for us. So just, Bridget, don't wait for me. At any point when it feels natural for you to just kind of walk through those, you can just make that happen. But here's kind of like my first question for you. So late last year, the Supreme Court hears the oral arguments with Dobbs. Our team listened to it live. We did a 2.5 hour live stream the next night about it. And if people want to nerd out about that, they can go find that in the podcast feed. But one of the interesting things that happened, and I'm sure you both know about this, was this idea that one of the pro-choice lawyers argued, like, hey, we don't need, anything new, more restrictive about abortion, because we don't really have any new information since Casey v. Planned Parenthood in 92. Like, what new things have developed there? And then fetal pain got discussed a little bit. And Justice Sotomayor said that only a small fringe group of doctors believe that fetal pain begins before 24 weeks.
That's
so
you,
Bridget, tell us, Why? I know, right? You guys are so friends. Why is she wrong? What has been learned since 1992 about fetal pain?
I think a great deal has been learned, starting with the very obvious fact that in the past 20 years, we've had the advent of 4D ultrasound technology, which has absolutely revolutionized the ability to observe fetal behavior. And fetal behavior actually reflects fetal neurodevelopment. So when we're trying to correlate what is actually going on neuroanatomically, we look at how the fetus is behaving. And grainy old ultrasounds in 1992 were very different than the 4D ultrasounds that we capture now that everyone is used to seeing. There are lots of people who have those pictures on their refrigerators of the 3D ultrasounds, that is. A lot has changed. We can see what the fetus is doing. And a lot of the studies that have come out in the last few years specifically look at how the fetus responds to anesthetic injection during fetal surgery. And there are prominent facial expressions of pain, which are similar, if not exactly the same, to what we see in preterm infants in the neonatal intensive care units. The same facial expressions that are indicated pain indicators at those ages are also present in the fetus, even before cortical milestones are achieved prior to 24 weeks. So that is fascinating. There are just an abundance of new research and evidence that points to the direction of fetal pain perception in utero prior to 24 weeks gestation.
Okay, so Bridget, you wrote a paper, and yours is even more recent than John's. And so maybe talk to us a little bit, kind of walk us through, maybe compare and contrast your paper with John's, and walk us through kind of what your understanding is of fetal pain as of right now in 2022. What should we know?
Absolutely. So I think there are several things in that. Comparing and contrasting to John and Stuart Derbyshire's paper, John's absolutely right. Derbyshire's name is on everything related to fetal pain. He was one of the authors that I've seen again and again throughout, and certainly that was through that I've reached out to several other authors of fetal pain, just thinking, and like John has said, been pleasantly surprised by the fact that they have been very forthcoming and receptive and responsive to my questions. And it's been a great dialogue in order to do that. So what I've discovered with fetal pain, first of all, that the cortex is not necessary for fetal pain perception, as John discussed, that we have the same reactions to pain in the fetus are present before 24 weeks. And they're also present after 24 weeks. So there's no change that happens that at this 24-week milestone of these fibers connecting to the cortex that shows their importance. Instead, we can see all the same markers, the fight or flight responses, the facial expressions of pain, and also behavioral changes to pain prior to 24 weeks. And then in clinical practice, we also see that we are treating pain in the neonatal intensive care units at 21 to 23 weeks gestation in these very earliest, extremely preterm infants. And pain is recognized by these neonatologists and those caring, like the nurses caring for these infants in the NICU. And then in the field of fetal surgery, the fetal surgeons are using pain medication during fetal surgeries as early as 15 to 16 weeks gestation. And they've had new recommendations come out just this past year by anesthesiology groups that have recommended pain medications in all fetal surgeries to blunt any perception of pain. So it's really remarkable. There's just a lot out there. And at a very basic level, I think women need to be informed that the fetus can feel pain, whether they are contemplating abortion or whether they are having fetal surgery for some sort of condition of their fetus during pregnancy.
Real quick question about the fetal surgery thing. Does anyone know, I don't, off the top of your head, the youngest babies who have had fetal surgery done? Like the famous baby Samuel picture, I think he was 20 weeks, if I remember right. I'm not
He's like 21
positive.
weeks, yeah.
21?
Right, yeah.
The earliest I've seen is 15 to 16 weeks.
Yeah.
Oh, wow.
Yes.
Okay.
Yeah, and frankly, that goes back to the 1960s with Sir Lilly from New Zealand, the founder of fetology. He was doing percutaneous blood transfusions, that is, needle-based blood transfusions for children as young as 16 weeks, even back in the 1960s.
It's amazing.
So when I was looking into fetal pain, gosh, probably 12-ish years ago, maybe 13 years ago. In fact, I actually had this really great volunteer. He's a pro-life paraplegic who has learned a lot about the nervous system since having become paralyzed. So he spent over a year trying to research this for me, and it was difficult. It's so complicated, and he wasn't a doctor or a scientist, so there was some kind of limitation there. But I remember back then hearing and feeling pretty open-minded to the argument from, people like Dr. Derbyshire, who was saying like, okay, you have multiple different components to the nervous system that are all like necessary to feel pain, and they also have to all be connected. It's not just a matter of the first few of them kind of coming online. Like they all need to come online, and they all need to be connected, or else you are not going to have, electricity get from point A to point B. And that made sense to me. Another thing that made sense to me, I basically want you guys to respond to both of these. The other thing that made a lot of sense to me was this idea that pro-lifers were sometimes pointing at early 2D ultrasounds. The Silent Screen movie is kind of the most famous, where you've got this ultrasound of a baby during an abortion, and kind of this idea that like look at how the baby is like moving around. And other people or scientists would say, yeah, but those are just kind of like these automatic, nervous system things. And so I heard both those arguments, and I was like, hey, maybe they're right. And so it seems that they probably weren't. So help me understand why both of those arguments turned out not to be correct.
So I would say one of the compelling arguments against the necessity of the cortex is some of these studies they've done, and they stimulate the cortex. And as surprising as it sounds, one of the gold standards for determining what areas of the brain are needed for something is to use electrical stimulation to those areas, usually in patients with epilepsy. And so they've done this multiple times on different studies on hundreds of patients, and they've stimulated various areas of the cortex, and they did not cause pain in a reproducible, this is a necessary for pain sort of way. So what they did find is that the thalamus would cause pain. Stimulation of the thalamus would cause pain. So this really raised the question, wait a minute, just as the two studies that John referenced, that, people keep saying the cortex is necessary for pain, but we can't prove it. And then you also have these extremely preterm infants, less than 24 weeks, who do not have those cortical connections, and they're demonstrating pain responses. So we're watching the behavior, not just the neuroanatomy. And I think that's a key part. And, John, feel free to jump in here, but I'll touch on the reflex issue quickly. I think what most people think of when they think of reflex is probably the knee jerk, the patellar reflex in the doctor's office. You tap on the knee, the leg kicks out, and then it goes back to a relaxed position. So, reflexes are stereotyped movements. They're predictable. You have a motion, and then it goes back to baseline. I will tell you, one of the compelling pieces of testimony that I read was from the 2019 Ohio State Legislature. And a radiologist was giving testimony there, and I referenced this in my article. And he was in the room for a feticide procedure. And this happened during what's called a selective reduction. And it was a woman who's pregnant with triplets. And they were trying to reduce the triplets down to just twins. And so during this procedure, what happens is a long needle is inserted through the maternal abdomen, through the uterus, and the needle then has to penetrate through the chest into the heart of the fetus, and inject a lethal medication. And so as this radiologist watched this procedure, what happened was that as this needle touched the chest of this fetus, who was less than 18 weeks gestation, there was immediate flailing. And as the radiologist described it, this fetus was fighting for its life. And so the person doing the procedure, the OBGYN attempting to do this procedure, had to try 2 or 3 more times because the fetus kept moving away. And again, flailing at each attempt. And they actually had to then move the needle to a different fetus, and were eventually successful. I think another compelling part of that testimony was that during the procedure, the monitor was turned toward the pregnant woman, and she just broke into tears as she watched the reaction of the fetus on the screen. And the technician was told to move the screen away so she could not view it. And the testimony of the radiologist said this was not a reflex. I mean, a reflex is a stereotyped behavior. Flailing does not represent a reflex.
Yeah. Anything that you would add to that, John?
Yeah, so absolutely. And I agree 100% with Bridget, and I have talked about this a number of times. So Sir A.W. Lilly, the father of fetology, talked about, he says, strictly speaking, we don't know if the fetus feels pain. Yes, but all I can say is it responds with vigorous, violent responses to things you and I would feel as painful. Injection of cold water or needle prick. Magda Dennis, who is no pro-lifer by any means, wrote an article, and I forget the name, Commentary Magazine. I think there's something about performing abortion or something like that. Powerful. And she talked about, I'm not sure if that was the one that she mentioned, but she has a book also that describes fetal response. And I think there was a mention of that in the Magda Dennis article in Commentary Magazine online available. Also, there's an article called What I Saw at the Abortion. It talks about this same thing, this kind of outside observers, reflections on what happened. And he saw the needle putting in, he saw it flurrying around. He's like, what's going on in there? That fetus is having a response. And there's also, of course, on the scientific side, 1994, and you thought Derbyshire was a tough name to pronounce. Gianna Kouloupolis, I think is her name.
Oh, wow.
Yeah.
Good job.
So definitely solid Greek name for you. But she and her colleagues, I think that was the one, Bridget, where they saw the increase in hormones and the violent responses to, again, the percutaneous needle poking of the fetus. And they're like, all right, so these stress hormones, these pain hormones, these endogenous opioids are going way up, skyrocketing, and the fetus is flailing around from fairly early gestation, mid-gestation. So all these things, yes, I would agree. The fetus responds in every way as though she feels pain, and it's incumbent on us. That's not at all what we would expect if she does not feel pain. We would expect more like what we see when we, say, anesthetize the fetus, that placid, quiescent, calm non-response, essentially, to these violent interventions. We would expect to see that if the fetus really did not feel pain. But instead, what we see is these violent, vigorous responses.
Okay, so I have a question, and either of you feel free to answer if you might not have an answer to this question, but what you just described raises a huge question for me. So if the father of fetology, did you say Dr. Lilly?
Yes, that's right.
Yeah. If he says this thing that seems to be like very reasonable, we don't know for sure it feels pain, but it sure acts like it feels pain. And that was in the 60s. Did he say that?
Yes, in the 60s. Yeah. He's been doing that since the 60s.
Okay. Then how did people like Dr. Derbyshire and so many other scientists get this so wrong? And as you think about that, I will offer one possibility. I have no idea. But I know even philosophers, even scientists can sometimes fall into the trap of confirmation bias, right? So if you have for example, a Christian scientist who is coming from a young earth place, they might just read an old earth kind of piece just a little bit differently, right, than someone who is either completely open-minded or is already in kind of the old earth camp. And we try not to do that. I'm sure we're all taught about confirmation bias in college, but it's just almost this automatic, everyone does it at least a bit, and it's just a matter of degree how much we do it. And so it would make sense to me if basically in the end it's look, we're all in confirmation bias land to some extent, and for sure a pro-choice researcher or a scientist, it would want to believe for multiple reasons that fetal pain can't begin until 24 or later weeks. And so that's one possible guess, but tell me, how did people get this so, from 1960 to 2010, we're saying maybe fetal pain doesn't even begin at 24 weeks or later. How?
Bridget, do you mind if I take this? All right. So back in the 1850s, with the first issue of what later became Journal of the American Medical Association, a doctor described anesthetizing humans and so on. He said there's really no need to anesthetize the newborn because they're not going to remember it anyway, and they're easy to control.
Right.
So, all right. So we essentially progressed from then until the early 1980s, not at all. because in the early 1980s, we were still not anesthetizing infants and newborns as a matter of course for even the most invasive surgeries.
Clarification question though on that. Like, was that sounds to me like a lack of compassion, not so much like we actually think that they're not feeling any amount of pain. Am I wrong?
I can jump in here.
Yeah.
Okay, go ahead.
Yeah, please.
Okay. So one of the things that certainly I found was, and I went back to research this because I had the same question you did, Josh, is how did we do this? And I think some of it started with the fact that I think we're all familiar with the fight or flight response, where, movements get more vigorous and, there's kind of a very visible reaction. Well, what was happening in some of the early research that happened in the 1900s into the 1950s, 1960s, what they did experiments. I should say experiments. I should say research. They did research on newborns, and they did pinpricks, electric shocks, pinching, and various different things. And they found in these really preterm infants, they weren't reacting like older infants and healthy children would. And so they started to think, well, they're just insensitive. But what has come to be realized through research is that it's a fight, flight, or freeze response. And some of these youngest and sickest babies were actually, due to lack of energy reserve, not responding. They might give one response and then their responses would be subtle, but they weren't as great as maybe other children or older infants. And so they were dismissed. What came to pass, especially with some of the studies in the 1990s and a non-study in the 1980s, was that they realized and they measured these stress hormone levels, and they found out that these babies did worse. So it's not too surprising if they weren't using pain medication for babies. They certainly weren't even going to consider the fetus. And, they even thought newborn babies back in the 1960s, were blind and really minimally conscious, if at all. So we've come a long way in our understanding. And I think the one other thing as far as giving pain medication to infants undergoing surgeries was back in the 1980s and prior, they weren't sure if they could do it safely. They didn't. There was no standard protocol for it, and they actually thought these critically ill infants, the youngest and the sickest, would actually maybe do more harm than good if they used pain medications. And I think two things that also occurred during that time period that also changed, in addition to the studies that they did on these preterm infants, there was one study in particular where they gave half pain medication before surgery and half they didn't. And there was a drastic difference. There was a drastic difference in their stress hormone response. Their outcomes were worse and so forth. And that study was published about the same time that two women also shared their stories in the news media. And these two women in the 1980s had both had preterm infants who had had surgeries without pain medication. And they just were horrified. They had no idea that was going on. There really hadn't been an informed consent process that they had been made aware of, that their babies were not receiving pain medication. One of the babies ultimately died. The other one had significant sequelae as far as extreme sensitivity to pain in the areas that had been operated on for years afterwards. So that combination of those studies with public outcry really revolutionized neonatal pain medicine. And then after that was acknowledged, then the question could be raised, how about the fetus?
Yeah. Okay. So does that bring us then to the 80s? Like, that explains what was going on up until that point. Okay. So then help me understand, and maybe we can go back to John and then back to Bridget from the 80s until 2010. Like, I don't want to jump all over Dr. Darbyshire because I'm so proud of him for being so open-minded and willing to change his mind. But like, given that he's was the primary name, there's 30-year gap there. And again, you've got Dr. Lilly in the 60s saying, boy, it sure kind of seems like fetal pain might be like a real thing. Like, can you help me understand what that gap was?
Yeah, and that is the heart of the question, isn't it? Okay, so I don't really know, except that this idea has been around for a while, from Rene Descartes in the 1600s, with the pineal gland being the seat of humanity, according to Rene Descartes. I think, therefore I am. Well, animals couldn't think, and they didn't have real souls, and so their cries when they were being cut open alive during vivisection in his day were just the sounds of deranged springs. They were just automata. They were just machines. And so, to some degree, I think that I think that attitude did affect even up to today. I think that it is still a very powerful idea. And it just highlights how much philosophy and linguistics plays a role in guiding the science and the interpretation of the science. But I think that, they're trying to say, hey, listen, if you're going to say that these patients, and I think this is true of Stewart, like according to this pain definition, which is the International Association of the Study of Pain, IASP, back in the 70s, these patients, nor animals, these even young children can't feel pain. So is that what you want from this definition? Because that's what I'm going by. According to this, here's what their neurology says to me. And I think that was the sticking point. And it, to some degree, to a large degree, I'd say that there is a sticking point. That is it. It's the definition of pain. And it's also, I think that abortion does play a role in it. Yeah, for sure.
Anything that you would add, Bridget?
Yes, just one thing that I would add there is that I think sometimes the history of medicine repeats itself. I mean, we look back, 50, 60 years, maybe to the 1950s, and we're thinking, we were doing lobotomies then. And we're thinking, what were we thinking? And now we're looking back 40 years or so into the 1980s and thinking we were doing surgery on preemies without pain medications. What were we thinking? I mean, there's a progression in evolution and understanding of medicine that occurs. And so if anything, it should teach us the caution. And one of the things that I think in medicine that we're all taught is correlation, correlation, correlation. When we see a screen, when we see a lab value, we're supposed to correlate it with the patient. If the screen shows that there's a flat line, but the patient is talking to you, you're going to believe your patient.
Exactly.
So that's an important thing. And I think that's something that we always need to look at. Let's look at what is the fetus actually doing. Let's not just say, well, it doesn't have cortical connections, therefore it can't feel pain. Let's actually see, now that we have the ability to have 4D ultrasound, how is that fetus behaving? And I think one of the interesting things, and John's aware of this study as well, is that one of the things that comes up too is, okay, maybe the pain pathways are there, but certainly not the pathways for consciousness. The fetus can't possibly be conscious in that first trimester. And so when we look at consciousness, what are we looking at? We're looking at the ability to respond to the environment, the ability to do planned motor activity, not just reflexes, but planned motor activity. Well, there's a fascinating study done on twins that looked at exactly that. They were trying to differentiate twins in utero and to see, were they moving reflexively or were they moving with some sort of intentionality? And what they found at 14 weeks, by 14 weeks, is that these twins would differentiate the way that they would touch inside the uterus. So if they were reaching out to the other fetus, that velocity of that movement was very slow. When they were reaching out to the uterine wall, though, the velocity was faster. When they were reaching to their face, which is a more sensitive eye or mouth region, the velocity was also slow. So there was a differentiation, and the slowest velocity of all was actually when they were reaching out toward the other fetus. And so it was fascinating that even at 14 weeks gestation, they showed, action planning. They showed, kind of a learned behavior and where the velocity of movement that's going on at that time. It's just amazing and fascinating that can occur.
That's so interesting. So it seems like then what I hear you saying, Bridget, is like when it comes to like especially anesthesia, but maybe other parts of medicine, I think I heard this analogy from you, but it just makes me think of it now. It's like the opposite of what like pilots are supposed to do, right? When they're like in the clouds, it's like, don't trust your instincts, trust what the dials are saying because they will keep you alive. And you're saying it's like the opposite was like, if your patient is saying this hurts or is acting a certain way, even if it seems to be going against what data you think that you have, then you should be paying attention to the patient.
Yes.
That is,
you trust your
really
patient, not your instruments. And then when you're flying, you trust your instruments, not your instincts. Yeah.
Well, let me put forth the other view. Yes, it is like flying in the clouds in a way. So the instinct. So I'm a pilot. So in the plane, we are context deprived if we're not looking at our instruments. We're just using seat of a pants, proprioception in medical terms. What we think we're going by our senses, it's wrong because our senses have been fooled by our inner ears. And there's that, I won't go into flight physiology, but so we really have fewer data points available in the clouds if we're not looking at our instruments. But in real life, with the fetus, for example, even if we're not measuring, their heart rate and their catecholamine release and their endogenous opioid release and their coding their facial expressions and their movements, even if we're not doing those things, we still have I would say even a richer supply of data points just from our own experience, our innate and interpretive ability of that baby's or that fetus's, however you want to say it, nonverbal cues of what they may be or are feeling inside. We have a rich supply of data, richer than any instruments that we could ever bring to bear on the fetus. And in fact, we tried in Bernardez's paper, Bridget, for example, where she codes exquisitely all the facial expressions, the eyebrow furrows, the grimaces, all these things that the fetus does in response to pain and so on, or let's say invasive stimuli. So we categorize, we count them up, we chart them and all these things. But really, our human perception that's innate and built in is very finely tuned for nonverbal interpretation. So that is a rich source. I'd say even richer, but we can't really get a handle on it unless we can measure it. But we know if someone's in pain just by looking at them, I would argue. And by the way, one of those papers for Roger, the adult who felt more pain despite his lack of the pain centers in his brain, they did the same thing with him in order to find out if he had pain. They judged by his actions. They categorized them. They rated them against his peers. They did not actually use any data from the fMRI, from his brain scans, in order to determine that he felt more pain, not less, no pain. They used all of his reactions, and they'll say, and I talked to Tim on this. I believe him to be a good faith researcher and defender of no fetal pain. All right. But he said, well, we took his verbal report. And what I say to Tim is like, look, Tim, that's still a patient response, and it is surrogate measure of pain. It's not actually, we don't actually have any objective measure of pain that we can put you on a scale and say, aha, that guy's feeling pain. If we did, that person who invented it would be very rich. We don't have that. So we have to take these surrogate measures of pain, which we usually use our eyes and our ears and our experience, frankly.
And that's one thing, too, that I have heard, I've read and I've heard from pediatricians who have been in the field for decades, is that they look back at how pediatrics used to be when they were just harshly immobilizing infants to do painful procedures. And they look back at it and they just shake their head. And they said, we saw all of their behaviors. We saw the grimaces, we saw the crying, we saw the tensing and so forth. But we were told that couldn't possibly represent pain, and they weren't going to recall it. And so if anything now, what we're learning from that is let's look, let's correlate, let's see what the behavior actually is. And let's not dismiss behaviors based on what our hypotheses about their neuroanatomy might be. And I think just to add to that, one of the things that was revolutionized when neonatal pain was acknowledged was pain management and pain assessment tools. And they were specialized. They were specialized for the stage of development of the infant. And that will need to occur as well for the fetus as well, because there are developmentally certain facial expressions they can make at certain gestational ages. And there's a point at which that, facial expressions, the musculature doesn't even develop till 16 weeks. So prior to that cannot necessarily be an assessment tool because you just don't necessarily have the facial musculature there to assess in exactly the same way as you would, say, an infant. So there will have to be, obviously an adjustment there to correlate with the appropriate stage of development.
Yeah. And if anything, maybe be extra cautious, like err on the side of being too compassionate or something like that. Okay. So Bridget, let's get to kind of the $1 million question here. Okay. And maybe this would be a good time for you to walk through your slides. Like, help us understand what you understand about fetal pain now, and ultimately, how early do you think fetal pain might begin as far as we understand everything right now, and why?
Certainly, I think there's evidence that shows the possibility fetal pain can exist in the first trimester. So I think to differentiate further than that, we're going to need further testing. We're going to need further studies. And I think that's going to just explode in the next 20 years. I think there's going to be, especially as fetal surgery is exponentially on the rise, I think there's going to be a great deal more research. One of the limitations right now with fetal pain assessments is that it is a crowded surgical field. And when fetal surgery is going on, you would have to have usually one ultrasound dedicated for whatever the procedure is, and then another ultrasound maybe to just examine the fetal responses, like the facial expressions and so forth. So I think that those sort of things and new technologies are really going to increase in the next 10 to 20 years that are going to revolutionize that. And that will help delineate when exactly in the first trimester that might be possible. But certainly we're seeing behaviorally with action planning and so forth that the fetus is capable of awareness of external stimuli as early as the first trimester. And that's really remarkable.
Okay, so maybe walk us through the slides and give us Fetal Pain 101. And for those that are on the audio podcast, I'll link to like a PDF or something where you can follow these on your phone if you want to. And of course, for the video version, I'll just drop these onto the video. But walk us through this.
Sure. And a lot of this is a summary of what we've already talked about. But the first slide in Evolving Understanding of Pain is really highlighting the fact, especially in that top timeline across the top there, is that in the 1980s, we only thought the older infant was capable of pain. The 1990s, that progressed to believing, okay, newborns can feel pain. In the 2000s, okay, the third trimester fetus, they're pain capable. Now in the 2010s, it's in the second trimester. And then certainly with John and Stuart Darbisher's paper here in the 2020s, that's down to the first trimester. So we can see over the space of just 40 years how much our understanding of neuroscience and fetal development and pain management has changed. And so that certainly should give us a voice of caution and making sure that we are erring on the side of providing pain management in these cases. Okay, and the second slide talks about a little bit more of the neuroanatomy that's involved and why they're differentiating hypotheses about when pain perception can occur. And so, as John talked about, the pain pathways have to start in the pain receptors, say in the skin, and then they go to the spinal cord, the brainstem, and the fat thalamus, and then to a unique fetal structure called the cortical subplate, which wasn't even discovered until 1974. And there's just been a tremendous amount of research on that in the last 5 to 10 years that has just shown that the subplate really is acting as a precursor for the cortex. And so instead of waiting until the cortex takes over, which in its permanent circuitry doesn't even occur till after birth and then continues in the postnatal time period, that we know that the cortical subplate has a really prominent role. And neuroscientists think that even has a role early on in pain perception. And so the bottom line on that is the cortical subplate is functional in the first trimester. And that's what John and Stuart's paper really, really highlights as well. The next slide talks about what the responses are, and that in an extremely preterm infant, less than 24 weeks, and the fetus, less than 24 weeks, the pain responses are exactly the same. So we have that fight or flight or freeze response, as we talked about, where we're thinking of cortisol, we're thinking of adrenaline type of markers, and we're thinking how that changes. And when you have a painful procedure, an adult experiences pain, they're going to have an increase in those stress hormones. Their heart rate's going to change, their oxygen levels are going to change, the blood flow is going to change. And that same thing occurs in the fetus. The same thing occurs in the preterm infant of the same age. And this is all, early on. It doesn't involve the cortex. Then those facial expressions of pain, we know those occur as well before 24 weeks gestation. We know those behavioral movements as well, which have been described as vigorous body movements, limb movements. There are pain assessment tools, that have been validated by the American Academy of Pediatrics as early as 23 weeks gestation, and they use these limb movements and as signs of pain. The clenching of the fingers, the clenching of the toes, the splaying of the fingers as indicators of pain. And we certainly see body movements in the fetus as well. So that just highlights the fact that we need to be looking at the responses, not just dismissing them because of their neuroanatomy. And this kind of puts that in chart form, that you have the fetus and the preterm infant. They both have an immature cortex. They both have an active and functioning cortical subplate. They have the facial expressions of pain, the fight or flight response to pain. They have body movements in response to pain. But for some reason, in clinical practice, the preterm infant will receive pain medication, but the fetus, according to the American College of Obstetricians and Gynecologists, and according to the Society for Maternal Fetal Medicine, cannot possibly experience pain. So the same responses that are in the preterm infant are therefore judged not the same in the fetus, according to those organizations. And then the last slide talks about levels of consciousness. This is always a big one. And what we know, and we know this intuitively, I think, just any of us who've had children and watched their development, it occurs over a spectrum. We're not the same as we develop from infancy to adulthood. And the same thing occurs with consciousness. There's a basic level of consciousness that occurs, and that's mediated below the level of the cortex. And that's the one we talked about that occurs even as early as 14 weeks gestation in these twins, where there's action planning, where there's learning going on, where there's planned motor activity, not just reflexes. And certainly the cortex is important. We know that the cortex will help us remember the past. It will help us reflect on the present. It will help us, anticipate the future. But an infant, a preterm infant, a young, toddler is not able to even do that yet because the cortex is not developed sufficiently. So we have to judge developmentally according to, like John said, the ability to feel a raw sense of pain, and just being in pain without having to reflect on it. That's still ethically significant. I think that's enough.
That's super helpful. Okay, we are almost out of time. I've got one more question for Bridget and then a couple for John. Bridget, what do you know about future research? Is there anyone working on the next paper right now, or is there a direction that that people are going, at least that you would be allowed to talk about? When could we expect maybe a better sense of when in the first trimester pain might begin? Any ideas?
Sure. That's a great question. And I think and I hope that studies such as these and research are going to continue. I am aware that there are going to be several publications coming out this summer on the topic of fetal pain. And so that's something to look for. I think that there are also new modalities that are being investigated from a technological perspective to try and assess the fetus. Because if we are giving pain management, we also have to assess, is it working? With fetal surgery in particular, one of the concerns with fetal surgery is the risk of preterm labor after the fetal surgery. And so what ends up happening is that one of the questions that arises is the injection that you gave the fetus at the beginning of fetal surgery, is it sufficient? Do you need postoperative pain management? And if you do, how technically is that going to be done? So there are questions like that could also improve fetal outcome and fetal surgeries that need to be looked at. So yes, there's constant research going on from the fetal surgeons, from the pain researchers, the neuroscientists. That really is just fascinating. That I think is really going to open up this field.
All right, I lied. One more question for Bridget. So for lay people who are like, oh, I want to know about the new things that come out this summer, where do people need to be following, or what do people need to be following if they would want to kind of learn about that when those studies come? Is there a certain medical journal or something that these are probably going to be in?
So I would recommend, if people are interested in knowing what peer-reviewed journal articles are coming out, you can go to PubMed and create an account, and you can set up alerts and you can select your fields. You can select fetal pain, fetal analgesia, fetal anesthesia, and you will get a lot of information very quickly. So, and it will keep you updated on what is the latest out there.
John, I'm wondering what the pro-choice response has been to your paper. I know, the pro-life response, at least for the pro-lifers who heard about it, was thought it was amazing. And just you, was the story behind the paper is about as fascinating as what was in the paper. But what has the pro-choice response been to it? I think when it first came out, I had read already, certainly Dr. Derbyshire was having his reputation, his career, at least as far as advocating for the pro-choice side, had certainly been affected. But what can you tell us about the response?
Silence for the most part. There was a brief flurry at the beginning. I know I talked to, I think she's now the current CEO of British Pregnancy Advisory Service, just briefly on Twitter. And she said, well, what about the woman's pain? I said, well, we already treat that. And then she said, well, what about the fetus's pain, the baby's pain, I guess, when he or she is being born? And I didn't respond to that. Stuart jumped in there, but in fact, it's well known in certainly the obstetric gynecological community And in fact, we were taught this in PA school, and it's borne out by many like fetal or obstetric anesthesia books, for example, that the pain and the stress of birth actually helps prepare the fetus, actually confers survival value by helping to maintain the fetus's temperature, to clear the lungs, and many other things that benefit the fetus's, the newborn's survival. So it does seem that, yes, it's very stressful, I'm sure, but it is also salubrious. Let's call that. It's good for the fetus, good for the baby. In fact, babies born by C-section are subject to transient tachypnea of the newborn, TTP, or TTN, excuse me. At any rate, all that to say is no significant response, but I anticipate more forthcoming because they're not going to let this stand. If it gets out in the mainstream, it's not going to stand, and that's fine. Bring it on. We'll see what's out there. I'm eager to see it.
Okay. And then a final question, and both of you can feel free to respond, but I'll actually start by giving my answer, and then just add anything that you would like to add, or feel free to push back if you disagree with anything I'm about to say. But basically, my question is, how should pro-life advocates talk about fetal pain, and what mistakes should they avoid? So the two mistakes that I can think on kind of either end of a spectrum would, one, the most obvious one being, like, pro-life people shouldn't be saying that abortion is morally wrong because of fetal pain, because if it turns out that, for example, fetal pain begins at 10 weeks, well, a lot of abortions happen before 10 weeks, and we're still against those. So it's not all just about pain, but I know a lot of pro-lifers kind of want to jump to, look, you wouldn't treat an animal this way, and so we shouldn't treat babies this way. But they can end up going too far, and I talk about this in my faulty pro-life argument talk. Like, we can go so far as to say, like, this is why, or the main reason why abortion is wrong, and this seems like something to avoid. And then on the other end of the spectrum, and this is a weirder case, but this did happen to me when, after I gave a talk in front of a relatively friendly audience, an older pro-life woman came up to me and told me her theory that fetal pain actually begins probably within a few days of fertilization, like at the blastocyst stage. And I was like, why? Why should I believe that? And she didn't really have any answer outside of, well, maybe like the soul feels pain or something like that. So that seemed a little bit kooky on the other end of the spectrum. But I'm interested. Any thoughts that you guys have? How should pro-life people talk about this subject as lay people? And are there any mistakes that they ought to try to avoid?
Yeah, thanks for that question, Josh, because immediately after our Stewart's and my paper came out, there was an article in the Daily Mail that says fetuses can feel pain at 12 weeks. And I was like, this is a big paper for me. Okay. And I kind of panicked because that's not what we didn't approach that certainty in our paper at all. And so I emailed the editor straight away and I was like, please change that headline to this. And so she said, okay. So they changed it, I think the next day or that day, to fetuses may feel pain. I was much better. But then I see it again. So I just recently published an op-ed at National Review a couple weeks ago. And I think Life News, I didn't realize they were going to pick it up, but my name's on it. And they changed the headline to a fetal pain. I can't remember what it was, but it was speaking in very certain terms about fetal pain. And I don't mind. Yeah, okay. So I get it. I do get it. But it's not certain. It's only certain in relation to what we know about animals. If we say animals can feel pain, then I think by the same standards, fetuses of certain gestation can feel pain. If you say animals can feel pain based on their behaviors, then we owe it to fetuses to say, yes, those same behaviors or similar behaviors and responses indicate that fetus can feel pain as much as the animal. If a newborn can feel pain based on these behaviors, then a fetus doing those same behaviors with those same responses can also feel pain. So I think we have to be careful in how we talk about it. Accuracy matters, or we lose our credibility, and that is difficult to regain.
Completely agree with that. Anything that you would add to that, Bridget?
I agree with John. I think that overselling what is being said is going to lose credibility. And so that is something very important in this. It's, yes, is fetal pain possible in the first trimester? Yes. But to definitely say it starts at this week or this week or this week is really extending beyond what we know. And so I think we have to be careful if we're going to try to back up what we say with science. We need to be intellectually honest and present the facts and not distort them.
Yeah, so this is a fantastic third thing that you've added to my list, but then this brings up one more question then, because I've had a lot of experiences with pro-life people who at least seem to get irritated with me when I try to add a lot of nuance to a simple, very concrete statement. And here you are kind of saying we've got to be careful to not make, more concrete statements than what we know. And so do you have some kind of a soundbitey, accurate way that you would encourage pro-life people to use when answering, if a pro-choice person directly asks them, when do you think fetal pain begins? What would be the accurate, but kind of in a few sentences way for them to respond to that?
Fetal pain may be possible in the first trimester.
That'll do. You guys are awesome. I'm so grateful for the research that you're doing. It helps people like me. People, we want to be accurate. We don't want to ever give medically false information or infactual information. And the level of time and research that you guys have put into something that is so complicated is really, really important. And I'm so grateful for you guys for coming on the show. Thank you so much.
Thank you, Josh.
Thank you so much.